All right, so a lot of our work is developing and testing digital health interventions focusing on mental health. And I think what distinguishes the work that we do is our work is always centered in equity and access, right? Hence the name of our research group, trying to figure out how these innovations can really reach folks who frankly need interventions the most, who experience the largest numbers of largest health disparities, et cetera. So that's always a focus of our work. As we know, there are billions of phones out in the world, and what we try to do is leverage these phones, these computers that all of us carry around on a daily basis to try to reach people and help them achieve better health outcomes. One of the challenges that we're kind of coming up against is that a lot of digital health tends to be designed for people who already have relatively good health, right? So when we think about, these are all kind of mostly Apple Watch kind of advertisements, but a lot of these interventions get started in Silicon Valley by and often for people with means. And while we can kind of work to maybe achieve optimum health and kind of help people become a little bit faster, maybe lose an extra pound or two, that's great. But how much population health are we actually achieving with that as the main driver of innovation? We also see that by language. So most, not surprisingly, most digital health apps are in English by a long shot. And so we're, again, by definition, excluding a large number of people all across the globe, but even within the US, with a wide range of languages that are spoken. And when you consider Spanish, for example, which is what a lot of our work focuses on, it's a sizable proportion in the US that can't access all the tools that are out there. So when we look at kind of mental health and digital disparities, more specifically, kind of the basis of our work is that racial and ethnic minorities are less likely to receive mental health services. So these are mental health services in the standard sense, right? Kind of going to a clinic, something like that. And when they do, they're more likely to receive lower quality care. So this is something that we've kind of known for a while. As you can see, this data ranges from 2004 to 2012, and the patterns haven't really changed. Patients from diverse backgrounds tend to face challenges completing even the core functions of apps. Some colleagues over at UCSF downloaded some of the most common apps at the time, so about 5 years ago. And as patients engage in some of the basic aspects of tracking your mood or typing in diabetes measures such as blood glucose or something like that, and found that a large majority of patients had a difficult time with some of these seemingly simple tasks. So again, underscoring the incompatibility of the existing kind of digital health tools with the folks who probably bear the biggest burden of public health challenges. So some colleagues and I, including Caroline, who you hear from soon, have really proposed that if marginalized and underserved populations are not considered during the development and evaluation of digital mental health tools, technologies might actually serve to further entrench rather than overcome existing disparities. This is something that we're always trying to be attuned to. Digital health could benefit health in general, but whose health is it benefiting the most? So who's digital health designed for? Not always the most, not always the underserved, challenges in language access, mental health and digital disparities, which I talked about a little bit. And then when we think about digital disparities broadly, folks from Latinx backgrounds are more likely to be smartphone dependent compared with whites. and are more likely than other groups to interact via text messaging or mobile messaging. This is a population that we focus on a lot. We also found that some colleagues found that 86% of Latinx primary care patients stated an interest in utilizing a healthcare app, and 40% expressed motivation to use such apps daily. So there is the possibility there that may not be being tapped to the extent that it can. And a big challenge also in a lot of this work is the low rates of African Americans that participate in mobile health intervention studies. So representation within the data, I think kind of a broader issue is kind of this idea of, when we talk about big data, who is in that big data? What is it composed of? Is it representative? And more so, is it reflective of the people who we need to know more about, of where we need to intervene the most? So this is an overview of technology adoption by kind of race, ethnicity. And what we see is, I talked about smartphones, and there are similar ownership rates of smartphones. So there isn't a big disparity there. That makes using smartphones an opportunity. However, when we think about just access to data and the internet, there are disparities when we consider desktop or laptop use, home broadband. There is quite a big difference. And these are becoming particularly relevant now when we think about the expanded use of telehealth, right? So now visits are going online. And so what this means is that a lot of folks from ethnic minority backgrounds are much more likely to use their phones, either use their phones for video, but even more so to just forego a video call and do a phone call instead. And it's not really clear, we haven't really documented, let's say, the difference in quality between a phone call versus a video call, but we can imagine, at least from in terms of kind of face validity, we can understand that there's some data that is transferred through seeing another person versus just being on the phone with them. And this transfers over also when we're developing, let's say, digital tools, making sure that they're not very data intensive and don't require a lot of data transfer. So the first set of studies comes from now a focus specifically on treating depression in the public sector. So all this work has been done at the General Hospital in San Francisco, which treats primarily low-income, publicly insured patients. And a challenge with depression treatment, so with cognitive behavioral therapy for depression, which is a gold standard treatment for depression, we find that when implemented, just a standard treatment, there are challenges in attendance. And we do know that attendance predicts improvement. So the more you show up to a session, the better off you're going to be. There's high levels of dropout. And part of this treatment requires homework completion. So we ask people to fill out some, let's say, mood ratings or review how their week has been. I'll show you a little bit in a couple of slides. The homework is completed at very low rates. So the dosage of treatment is a problem in these settings. Here's another view. So the treatment that we focus on that I'll talk about here really is meant to last 16 weeks. So you would expect a bump of number of participants kind of finishing at 16 weeks, but instead you see a high number of people only completing 2, 3, 4 sessions, so high levels of dropout. We know attrition is a problem in mental health treatment. It's common, but it's worse for low-income and ethnic minority patients. And there's also high levels of attrition for technology-based interventions. So our goal was to leverage text messaging to improve treatment quality and engagement for depression. And why text messages? The part that I left out is this work kind of started in about 10 years ago, in about 2010. So as smartphones were being developed, but not as widely used as they are now. But text messages are even more accessible than kind of smartphones and all the apps that people use within smartphones. Cost efficient, there's high levels of engagement. Some estimates that say people open, over 95% of text messages that they receive. And I think from experience, we can probably relate to that. There's also a greater sense of personal connection via text message compared to, let's say, an app notification. So this is the clinical context of this text messaging program. It's part of a treatment that meets weekly for 16 weeks, has 4 modules. We focus most of this data on Spanish speakers. And we did a trial where we compared one arm that got the standard treatment and another that got the text messages plus the standard treatment. And I was actually part of this clinically with a couple of other clinicians. And here's an overview of the sample. Some key notes are the average age is 52, so not folks who are, necessarily the early adopters in technology always, or the targets of things like texting interventions. Oftentimes we associate those with folks in their 20s maybe. And this presented some opportunities and challenges. For example, folks who maybe don't text as much, the messages that we send them are relatively more impactful, right? Because it's one of maybe 10 messages a day, if that, versus one of 50 or 100. Most folks did not complete high school, and almost everyone owned a smartphone. But about 3/4 use text messaging. And I think that's interesting to point out that that difference, because although we know that nowadays almost everybody that has a phone owns a smartphone, we can't assume that they know how to use all of the features of the phone, right? So even if we develop an app, they may or may not be able to engage with it. So the way that we started doing homework in this context is using a form such as this, where we'd ask people to indicate the day of the week and then indicate their mood over each day, and then answer some other prompts such as this one: how many healthy activities did you do each day? And the goal is to connect the mood with, in this case, activities or with thoughts, etc. And the components of the intervention are mood monitoring, which I just showed you kind of what the basis was, theme-based text messages. So this is kind of related to what's going on that week, the focus of that week. It's kind of like a class. Medication reminders, and then group attendance reminders. This is what the mood monitoring text message looks like. Respond with the number from 1 to 9. And then we ask them to write a little bit about what's going on, what they're doing or what they're thinking, because we want to make those connections. And these went out randomly between 8 and 9 p.m. And we provided feedback randomly to about 20% of responses, in part because we wanted to have some interaction, but we don't want to respond to every single message, because we know that kind of not knowing when you're going to get a response is actually related to continuing to engage, similar to the effect that you would have with a slot machine, right? And this is examples of some of the content that we sent. So if somebody sent a high mood, I might say, it looks like you're feeling good. Think about what you're doing and thinking to keep your mood high. If somebody responded with a lower mood, we'd kind of try to reflect that idea as well. These are the theme-based text messages, so they're related to what's going on in session. So the modules are 4 weeks where we talk about thoughts, 4 weeks about activities, 4 weeks about interpersonal and social relationships, and then 4 weeks about kind of general health. This is a medication reminder example. and the group reminder the day before session. All right, so now in terms of getting a sense of what it looks like, so this is an example of what the data looks like when we get it uploaded into the system. Here I'd like you to focus on the pink graph. And this is an example of a patient's data. And the way we'd use it in session is to say, okay, let's look overall. Your mood looks to be pretty positive. It ranges from a 6 to a 9. And let's focus on some difference, some change points. So on Tuesday, this patient reported a 6, estoy en casa, I'm at home, right? Compared to Wednesday, reported 8, estoy con una amiga, I'm with a friend. Right? There's a discrepancy there in terms of the activity that this person's engaged in, and we use this as a teaching point then to try to reinforce the skills in therapy. And in terms of some of the key findings from this study, we saw mostly in terms of engagement with going to the therapy sessions. We found that folks that received the text messages showed up to 6 sessions versus about 2.5 sessions for the non-texters. And in terms of week until dropout, the difference was even more pronounced. So the median week of dropout for texters was about 13.5 weeks out of 16. So almost the entire duration of treatment. Whereas for those not receiving text messages, the median dropout week was week 3. So this is a pretty pronounced effect. And I think an example of how continuing to be in touch via an automated means using text messaging can have the impact where even if somebody is going through a difficult time and stops going to treatment, they can re-engage later because we still have some communication with folks. So one implication of this is that we can help lengthen stay in treatment and hopefully help more people get better in the long run. And now that we have this data, we can also look more closely to try to make predictions based on the data. So we wanted to see, can we determine the likelihood of showing up to session based on the data that we've received? And sure enough, we found that mood ratings the day before going to session were related to whether or not someone was going to show up, such that for every 1 point increase in mood from somebody's average, there's a 32% increased chance of attending, right? Or vice versa, lower mood, 32% less chance of attending. This information is valuable because then it can identify points for a micro intervention or tailoring. We can outreach to people that may be at risk of not showing up. We also wanted to see, okay, we're asking these mood ratings on a daily basis. How do they map on to kind of gold standard clinical ratings? The PHQ-9 is a measure of 9 symptoms of depression that's typically used in clinic settings. And we did find that indeed our mood measures over the past week were related to PHQ-9 ratings. And so why is this important? In some ways, it's relatively straightforward, but there's an implication that we may be able to use simple mood ratings via mobile phone to assess symptoms versus having to do a long questionnaire. And this is particularly relevant for folks with lower levels of literacy, for whom doing a 9-item assessment can take 15 minutes, right? And it may allow for a remote monitoring of larger numbers of people. Because we're interested in kind of cultural factors and getting a sense of the experience of our participants, we also asked folks what the experience was like. And so some English speakers in the earlier stages of the development responded by largely saying that they found them helpful, made them stop and think about how they were feeling. I think the last comment here is pretty indicative, I think, of the patient population. Sometimes I'm so busy, I hardly stop and think about how I feel. Now that I'm getting texts, I stop and think every day. When it stopped, I missed it. My life is crazy. I need a reminder to think about how I feel. So people found a way to kind of integrate this into their lives and take a moment, which is something that we encourage in a therapeutic context. Spanish speakers also tended to find it helpful. And as you can see, there's some slight differences in the type of feedback that we're getting here. If you notice, one patient said, I felt cared for and supported. I realize that someone cares for me and I don't feel alone. They make me feel that that there are people that care about my health. So here we're starting to see some cultural differences between folks who are primarily from Latin America, immigrants, from a more relational context, talking about the relational aspects of the intervention of text messaging, versus the English speakers are focusing more inward. And we know from kind of cultural psychology and other work focusing on cultural differences that there is, in the US, we tend to have more of an independent kind of framework, whereas in Latin America, the relational framework tends to predominate. And this feedback reflects that. And it's important because we often think about doing an intervention and everyone's getting the same thing. But the reality is that they may be getting the same content, but the interpretation is different based on what one brings to the table. In terms of suicidality, this is a concern that we kind of address by telling people that this is not direct communication. But even though they know that, patients still feel a sense of connection. There are keywords that are triggered if they're sent into the system that get sent to us so that we can go in and monitor the messages. Fortunately, to this point, we haven't had anybody trigger any of these words in a real meaningful way. So the lessons learned so far with this intervention are the patients who text attend more and stay longer. Prior day mood predicts attendance, and mood ratings via text can approximate PHQ-9. And generally, patients have reported that they like interacting with automated text messages. So this is kind of the first set of studies, the first project that then led on to another study where we're trying to increase physical activity with folks that have depression and diabetes. And it kind of came from this work because we saw that people who were struggling with depression also had other health problems that were making their depression worse. And so Caroline will, I'll turn it over to Caroline and she can talk more about that.
Okay, good. Yeah, so I'm gonna shift a little bit and talk about some of our broader framework of working on digital health, social justice. So Adrian gave some really nice concrete examples of how we're using text messaging in our lab. And another thing that we're working on is creating these broader sets of questions around what should researchers think of when they're trying to develop digital health for social justice. Before I start, I wanted to hear from you and ask you if you've ever used a wellness or health app, and if so, how it was. So if you can just paste your answers in the chat. Any experiences that you may have. Never used one. Yes, worked pretty well. Never tried it. Yes, tried a couple, never stuck to it. Okay. They were too basic. Tried it, but it started working and I felt like I didn't need it. Spell, which is spammy but gets the job done. Hard for someone who doesn't use tech. Not well designed, they never stick. Okay. Thanks very much. That is helpful. So there are currently over 325,000 mobile health apps available in the health app stores. And as Adrian was also mentioning, this is only growing increasingly. And with the COVID-19 pandemic, digital health is even growing more exponentially. And just to give you an idea, when I talk about digital health, what I mean is things like mobile health apps, but digital health is really broad. So it can also include things like telemedicine, video calling with doctors, and even things like collecting a lot of data to improve health systems. But today I'm mostly going to be talking about mobile health apps. So what we are working on is building a digital health social justice toolkit. So what I will be talking about in the next 20 minutes or so is what we mean by digital health social justice, why it's important. And I'm also going to give you some of the first ideas that we have so far identified around what needs to be included in this toolkit. And we are building this for researchers who want to design digital health interventions. So when we talk about social justice, one of the main important aspects of social justice is the idea that everyone is entitled to human fulfillment, whether that's in work, whether that's in education or in social participation. And that's also the case in health. So to step back a bit, let's think about what do we mean when we talk about health. So I don't know if there are any health researchers here today. I myself am trained as a medical doctor. And I remember that when I was in medical school, I once took a public health class, and it was about the history of public health. And the teacher was a well-known researcher in his field. And he had all of us students sitting around in a circle, and he walked around in the middle of the circle while he was educating us. And sometimes he would ask people questions. And at one point, he turned to me and he asked, "Can you tell me what health is?" And I, as a first-year medical student, thought I should know what health is, because I'm planning to make a profession out of health. But as everyone was watching me, looking at me, and I was racking my brain trying to come up with the answer, and I realized that actually I didn't know. So I said the one thing that would seem the most logical to me, which was not being sick. And as I said that, I just saw his face darken, and I realized that that was not the right answer. So that was a very embarrassing moment for me, but it did always stick by me to remember that health is actually a very broad definition, because what we mean by health is a state of complete physical, mental, and social well-being. And it's important to think about this when we talk about digital health, because we're not just talking about fixing illness, but we're talking about helping people to achieve this total state. So the way that we define digital health social justice right now is as the equal opportunity for everyone to have access to, use, and benefit from digital health, with the objective being to achieve their greatest standard of health. And what the project is in essence is we're developing guidelines and tools for designing, evaluating, and testing digital health for social justice. And just to give you some background, this is part of a UC Berkeley Changemaker Technology Grant, and Professor Harding was one of the recipients of this grant. And I work with the dLab, so I'm also a fellow at the dLab. And these are some of the students that are also working on this toolkit, and they are some of the driving forces behind it. So I just want to acknowledge them. So what is in the toolkit right now is we're thinking of what are the main big questions that researchers need to ask when they're developing digital health for social good. And these questions are very targeted towards digital health, but we think that they are bigger questions that can be applied in other health fields or maybe even research in general. And what I would like to do now is present to you 4 of these questions that I'm going to highlight. And I would love to hear your opinions. Are we asking the right questions? Are we missing anything? Do we need to reframe things? Right now, it's something in development, so it would be great to have some of your opinions at the end of this meeting. So the first question is, who is represented in my research and why? So Adrian already touched upon this when he talked about digital health and who it's being developed for. So who uses mobile health apps? Well, you already got the answer to that a little while ago. So we know that currently the main users of health apps are young, highly educated, white, in excellent health, and high income. So arguably, they are the people that probably need these interventions least to improve their health. They probably have other resources. So one thing to reflect on, and these are some other scholars that have said this, is to determine the social value of a digital health project, one must first identify what constitutes a social disadvantage. So in other words, who should I design these interventions for? Who is going to benefit the most? What kind of problems can I solve that are going to make the greatest difference? So these are some of the questions that we think that researchers can reflect on. So as I said, who would benefit the most, but also how can I reach them? So we know from our research with low income Latinx populations that these are the people that are not as easily reached because they might not have digital skills. They're not as quickly to sign up to research studies. And there's for a lot of minority population, there's a lot of mistrust in medical research. So another thing you need to think about is how can I reach these populations? And then what kind of issues are they facing and what resources do they already have? So again, one of the things that we are doing is mental health, access to mental health resources. And we know that minority populations like Latinos and Black Americans, they have less access to mental health care. So these are some of the questions that researchers can ask if they want to achieve social good with their interventions. So the second part is, how can my research address societal injustices that prevent good health? Now, this is a really big question, and it's a difficult question. And we're certainly not thinking that we know all the answers, but we do think that this is a very important question to think about as a researcher. So over the last year, there's been a lot more attention to systemic injustices and how they affect health. And with the racial injustice protests over the summer, there have been more medical institutions that have recognized that systemic racism is a public health crisis. So what public health researchers talk about is the framework of the social determinants of health. So that's the notion that things like access to quality education, access to quality healthcare, living in safe neighborhoods, having a social support system, and having economic stability, these are all factors that can predict health outcomes. And in the US, for example, Black people, Hispanics, Indigenous, and other people of color have historically been discriminated, which has decreased their access to all of these resources. And that has led to worse health outcomes for these populations. So just to give you a really quick example of how that works, how that might work, this is the current situation in COVID, where we're seeing that minority populations, Black Americans, Hispanics, are more often dying from COVID-19. And that is research is showing that that's because of a lot of these structural factors, including having less access to testing, living in high density neighborhoods, not being able to social distance, exposure to pollution, or already having medical conditions, and being an essential worker. And then there's also a concept of racial bias in healthcare. I'm not going to go into all of this in depth, but it does show that these injustices in society can have a really big impact on health. So an important question would be, how can digital health solutions contribute to that? And just to give you one example, digital health, so our mobile apps, they're currently really focused on individual behavior as a factor that determines health. So for example, let's say you have a mindfulness app against depression, and the mindfulness app is telling someone that they have to go find a quiet space to meditate. But what if you're living in a really crowded place with a lot of people and you don't have anywhere where you can find a quiet space to meditate? So these are things that a lot of apps don't think about, that they will not work for everyone. So some of the questions that researchers could ask is, how do societal injustices influence participants? How do they influence their barriers to good health? And then how can my solution fill any gaps? So whether that could be connecting people to resources, or identifying, understanding what their barriers are and identifying how you could help them with that. For example, if you have, one of the things that we're working on is physical activity app. And with that app, we're really trying to identify opportunities that people have for physical activity in their neighborhood, instead of saying, why don't you go to the gym, as they might not have money to pay for a gym membership. So you just need to think about meeting people where they are. So the third point is, does my research aggravate societal biases, stereotypes, and discrimination? So in everything we design, we're bringing our own biases into that design. There has been a study, a qualitative study, that looked at apps, health apps that were in the App Store. And then they looked at the gendered aspects of these health apps. And what they found was that apps that are mainly targeted for women have a lot of stereotypical female designs, including pink colors, flowers, hearts, whereas apps that were designed for men, so for example, they looked at fitness apps, were more often about strength and individualism, and female apps more about beauty and femininity. And they also looked at sexuality apps and found that, for example, pregnancy was at the heart of those kind of apps. So there's a lot of stereotypes that these apps can reinforce, and not everyone is going to feel included by these apps. And we've made some of those mistakes ourselves. So I did a study a while ago around helping people to increase their physical activity through text messaging. And one of the messages that I had was, physical activity will help you look more attractive. And then some users commented that they didn't like that message because it wasn't about health, it was about reinforcing them to adhere to societal norms of attractiveness. And I hadn't been thinking about that, because I was just thinking about what is going to be effective, what's going to nudge people. But it's really important to think about the broader picture of what your design is saying. So, and there's situations that can be really dangerous. So consider someone who has all the symptoms of a classic heart attack. So someone with chest pain, who smokes, who has a history of panic attacks. And there are some apps out there that will help you. You can fill in your symptoms and it will give you a diagnosis. So there's one app in the UK, which is called the Babylon app, and it's actually being used by the National Health Service. And one user who tested out this app found out that when you put in the classic symptoms of a heart attack, but you only change one thing, which is the gender of the user, you get different results. So here, for a female user with the classic symptoms of a heart attack, the app suggested that it was a panic attack or depression. Whereas for the male user, it did find the more severe heart attack types of symptoms. So people were posting death by chatbot, gender bias, and one of the reasons that this is so painful is because historically women have been excluded in medical research, leading to a lot of biases in medicine, leading to a lot of diagnoses like heart attacks going undiagnosed, leading to higher deaths. And you can see that these kind of societal biases can easily sneak into the algorithms that are powering these apps. So some of the questions that researchers could ask themselves are, am I using bias-free language and design? Is my research team diverse? Because we know that more diverse teams lead to less problems being overlooked and less bias and also more creativity. And are there any differences that I expect based on subgroups within my study? Is there a good reason to analyze this? What would be the pros and the cons? And then, is my population diverse enough? Because having a representation in your research can also decrease biases. So I'm coming to the final point. What are my responsibilities in protecting individuals' privacy? So this is based on a participant in our research study. So we're working on a physical activity app, which helps people increase their physical activity by sending them motivational messages. So what we do is we track their activity, which is how much they walk in a day, but we also track their location. So this participant, Marlene, she wants to increase her physical activity, but she's also afraid of privacy issues because she has a status as an undocumented immigrant. She doesn't have she has low tech skills and she only speaks Spanish. So with this, in this case, it becomes even more important to think about privacy, because if privacy is breached for this participant is a lot more vulnerable because of her documentation status. And we know from research that it's quite easy to re-identify de-identified data, and it becomes easier the more data you collect, and it becomes easier when people have certain characteristics that are unique. So what researchers could ask is, what data is absolutely necessary to answer the research question? I think we have a tendency to think that more data is always better, but there are certain risks that come with collecting more data. So there needs to be, you need to really think about the data collection process. And then, how would privacy breaches affect my participants? And here it's important to think about privacy and security means different things to different people, and privacy breaches will have worse consequences for different people. And then, what is my role in educating and protecting participants beyond just the role of the of informing the institutional review board? Also, what risks do my individual participants have, and what is my duty as a researcher to protect them? Okay, so these are some of the questions. So just to summarize, we are working on digital health social justice, and this is needed for several reasons. For the reason that not everyone is equally represented in digital health. I've talked about the users, but it's the same when it comes to designers and the leadership. And there are different issues like racism, sexism, structural discrimination, privacy and security that can lead to dangers of digital health. And I've talked a little bit about some guidelines and questions for researchers that want to work on digital health to promote social justice. And these are the 4 questions that I talked about today. And I would love to hear some of your ideas, opinions, or any other questions that you may have. And there's a list of people to thank.